You've been looking at patients with refractory or relapsing chronic lymphocytic leukemia, and you've been using this agent Idelalisib. What were you trying to do, and what was the basis, what was the reason, the issue you were investigating here?
So the problem is that though we have increasing treatment options, relapse in CLL still is inevitable. We're not curing patients with CLL, so patients end up with relapse and often refractory disease that's not responding to conventional treatment anymore. So we wanted to ask the question whether addition of Idelalisib to a standard of care regimen for the relapsed refractory CLL patient, that is bendamustine and rituximab, would improve outcome.
Now, this drug is targeting an inhibitor of PI3 kinase delta. What does that mean, and why is it important potentially?
So the PI3 kinase pathway is actually important in many cell types. It's not just important in CLL and lymphoma. It is a critical pathway for regulating cell growth and survival. There are multiple isoforms, alpha, beta, gamma, and delta, and they have different tissue distributions. The delta is actually useful for us as hematologic oncology doctors because it targets white blood cells. And we don't see the targeting of some of the other tissues, and therefore we get less toxicity. So the delta targeting allows us to deliver much more effective dosing and really inhibit the PI3 kinase.
You looked at 416 patients, a very substantial number of patients. What did you find?
So we compared 209 patients who received bendamustine and rituximab plus a placebo versus 207 patients who received bendamustine and rituximab with the Idelalisib. And the primary endpoint was progression-free survival. And what we found is that the progression-free survival for the patients receiving bendamustine and rituximab and the placebo was 11.1 months, completely in line with what we expect. But when we added Idelalisib, we added 12 months to progression-free survival, going up to 23.1 months, representing a 67% reduction in the risk of progression or death.
And this was such a big effect that at interim analysis, the study was halted early.
Yes, the study had a planned interim analysis when 2/3 of the events had occurred, and that occurred in October. And in mid-October, the Independent Safety Data Monitoring Committee met and actually recommended immediate discontinuation and publication of the information because of the overwhelming benefit in favor of the experimental arm.
So I can't resist asking you about response rates and complete responses, and of course the possibility of overall survival being increased.
So the complete response rate was the overall response rate was 67%, which was about a 20% improvement over the bendamustine and rituximab arm. The complete response rate was higher, but it was actually quite low. The overall complete response rate was only 2%. Now, I know that part of the problem is that we used very stringent definition of complete response, and in CLL, to abide by this stringent definition of complete response, it requires a repeat bone marrow biopsy. And 24 patients in the Idela arm met the criteria for a complete response, but only 5 of them had a bone marrow biopsy. Those 5 were all negative, but the other ones couldn't be called a complete response because they didn't have a repeat bone marrow. In the bendamustine rituximab arm, there were only 8 patients who met the criteria to be called a complete response if they had a bone marrow, but none of them had a bone marrow either.
And overall survival?
Overall survival was significantly improved. In both arms, the median hasn't been reached, but there was a 45% reduction in the risk of death in the experimental arm.
Toxicities?
Toxicities were greater with addition of Idelalisib, but in a way that we expected. We saw more transaminitis. Well, that's a known toxicity of Idelalisib. It's manageable. There were more respiratory problems. Pneumonitis is a known complication of Idelalisib. Whether all of this increased respiratory symptoms were infection or drug toxicity, we're not sure. And we also saw some more rash and diarrhea. And those are all Idelalisib side effects. The thing that we saw more febrile neutropenia, and it was a significant increase in febrile neutropenia. There were no deaths from febrile neutropenia, and the rate of sepsis was actually similar between the two arms. One of the interesting side effects of Idelalisib is pyrexia, and because we're combining the Idelalisib with chemotherapy, the chemotherapy is causing neutropenia, and if the drug is causing pyrexia, those are automatically going to be assumed to be febrile neutropenia. So we see more episodes of low blood counts and fever, but they're not turning out to be serious, life-threatening infections.
Right. So there's something to cope with there, but manageable. You think?
It's all the increased side effects are very manageable.
What are the clinical implications coming out of this then?
So the clinical implication is pretty straightforward. For patients in whom the physician is thinking bendamustine and rituximab is the right thing to do, then addition of a small molecule PI3 kinase delta inhibitor, Idelalisib, will provide meaningful improvement over the standard of care.
Short take home for doctors?
We're in a great era, and this is not only a take-home for doctors, it's also for patients. We're in a great era in CLL. We have lots of drugs. Our challenge today is how to figure out how to combine them to really completely change the natural history of this disease, and we're only going to do that with our colleagues in the community, putting patients on clinical trials, and the patients being willing to participate in them.